This is PediaCast CME.
Welcome to PediaCast CME, a pediatric podcast for providers. And now, direct from the campus of Nationwide Children's, here is your host, Dr. Mike.
Hello, everyone, and welcome once again to PediaCast CME. It is a continuing medical education podcast for healthcare providers. This is Dr. Mike coming to you from the campus of Nationwide Children's Hospital. We're in Columbus, Ohio. It's episode 82 for December 14th, 2022. We're calling this one Diagnosis and Management of ADHD. I want to welcome all of you to the program. And welcome to the final episode of PediaCast CME for the year 2022. It's been really terrific traveling on this journey with all of you as we consider the health and well-being of children. We have lots more in store for you in 2023. That schedule is coming together. But we also have plenty of room to cover some topics that might be on your mind. So this would be a terrific opportunity to visit the contact page at PediaCastCME.org and suggest a topic for next year. Would love to hear from you. Also, as we approach the holidays, all of us here at PediaCast CME and Nationwide Children's want to wish you and your family a very happy season of celebration. As for us on PediaCast CME, we are celebrating the end of 2022 with a topic that impacts millions of families each year. And that topic is attention deficit hyperactivity disorder, otherwise known as ADHD. And we are covering all aspects of the illness today with a particular focus on making the diagnosis and differentiating this disorder from other problems that cause similar signs and symptoms. And we'll also focus on the management of ADHD, including behavioral strategies and medication. We'll also consider epidemiology and pathogenesis and best practices for supporting these kids from the family and school perspectives. So lots coming your way as we close out 2022 on PediaCast CME. To help us understand ADHD and its treatment, we have two terrific guests joining us in the studio. Dr. Abigail Caserta is a pediatric psychologist at Nationwide Children's Hospital, and Dr. Kristina Jiner is a pediatric psychiatrist at Nationwide Children's. Before we get to them, let's cover our usual reminders. Don't forget you can find PediaCast CME wherever podcasts are found. We're in the Apple and Google podcast apps, iHeartRadio, Spotify, SoundCloud, Amazon Music, and most other podcast apps for iOS and Android. If you like what you hear, please remember to subscribe to our show so you don't miss an episode. And also please consider leaving a review wherever you listen to podcasts so that others who come along looking for free continuing medical education credit will know what to expect. Speaking of that CME credit, it is easy to claim yours. Simply listen to the podcast, which you are about to do, and then head over to the show notes for this episode at PediaCastCME.org. This is episode 82. You'll find a link to the post-test in the show notes. Follow that link to Cloud CME, take and pass the post-test, and the Category 1 credit is yours. We offer credit to many pediatric professionals, including doctors, nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and dentists. And Nationwide Children's is jointly accredited by all of these professional organizations, so it's likely we offer the exact credits you need to fulfill your state's continuing medical education requirements. Of course, you want to be sure the content of this episode matches your scope of practice. Complete details are available at PediaCastCME.org. We're also on social media. We love connecting with you there. You'll find us on Facebook, Twitter, LinkedIn, and Instagram. Simply search for PediaCast. And once again, we have that handy contact page if you would like to suggest a future topic for the program. Again, that's over at PediaCastCME.org. Also, want to remind you the information presented in every episode of our podcast is for general educational purposes only. We do not diagnose medical conditions or formulate treatment plans for specific individuals. Our discussion may contain only a portion of relevant information and should not be solely relied upon for the diagnosis or treatment of any medical condition. We do not cover every possible treatment option, and the treatment options we do cover do not include every possible use, precaution, side effect, or interaction. Also, your use of this audio program is subject to the PediaCast CME Terms of Use Agreement, which you can find at PediaCastCME.org. pediatric.org. So let's take a quick break. We'll get our expert guests settled into the studio, and then we will be back to explore the diagnosis and management of ADHD. It's coming up right after this. Dr. Abigail Caserta is a pediatric psychologist at Nationwide Children's Hospital and an assistant professor of pediatrics at The Ohio State University College of Medicine. Dr. Kristina Jiner is a pediatric psychiatrist at Nationwide Children's and an assistant professor of psychiatry at Ohio State. Both are passionate about helping children, teenagers, and families live their best lives, which includes those impacted by attention deficit hyperactivity disorder. That's what we're going to talk about today, the ins and outs of ADHD, including epidemiology, pathophysiology, the signs and symptoms, differential diagnosis, arriving at a diagnosis of ADHD, and then management, risks and complications of medicine, risks and complications of poorly treated ADHD, the role of parents and schools in supporting these kids, and the long-term outlook for those impacted by this very common disorder. So lots to cover, but let's begin with a warm PediaCast welcome to our guests, Dr. Abigail Caserta and Dr. Kristina Jiner. Thank you both so much for joining us today.
Thanks for having me.
Great to be here.
Yeah, really appreciate both of you taking time out of your busy schedules to join us. Abigail, I wanted to start with you. Let's just talk first definitions. So what exactly is attention deficit hyperactivity disorder, or ADHD?
Sure. So as you mentioned, it is a neurodevelopmental disorder, and it stands for attention deficit hyperactivity disorder. This can be confusing because a lot of families say, well, my child doesn't have concerns with hyperactivity because ADHD was formerly known as ADD, attention deficit disorder, so it didn't encompass that hyperactivity in the name. But by definition, we're looking at a neurodevelopmental disorder. Again, that's attention deficit hyperactivity disorder.
Yeah. And sometimes there's a hyperactive component to it, and sometimes there isn't necessarily.
Correct. So there are 3 different presentations. A child may present with ADHD with only symptoms of inattention. They may present with just symptoms of hyperactivity and impulsivity, or they may present with both or a combined presentation.
Yeah. And this is really pretty common, right?
It is, yes.
How many children and teenagers are affected?
So the estimates, they range anywhere. You'll hear from 4 to 12% of youth. I think most experts would agree we're hovering around that 8% of the population of our children and adolescents.
Yeah. So really, we're talking about millions of children and teenagers with this disorder. So probably one of the more common things that we've talked about on PediaCast. Is there a difference in boys versus girls?
There is. So it's at least 2 times more likely to be diagnosed in boys. I think there are a few factors driving it. One of them being that boys are often presenting with the hyperactivity and impulsivity. Those symptoms are more observable and easier to detect.
Yeah, and impact others more. And so that, brings it to the parents' attention, who then brings it to the pediatrician's attention. What about at different socioeconomic levels? It seems like this could be one of those disorders where there's a disparity depending on how well you're plugged into a medical system. Are there a lot of kids out there with this who do not get diagnosed?
Yeah, I think you're spot on with that. And when we think about access to care and good care at that, making sure that we're in regular communication, not only with our physician teams, but also with schools, and identifying these kids who may otherwise really struggle and slip through the cracks.
Yeah. Kristina, I want to bring you in. We talk about risk factors for ADHD, both genetic and environmental. What are some of those risk factors where, if we see a kid with these things, then we should pay extra attention to the possibility that they might have ADHD?
Absolutely. So I think genetics plays a large role in the risk for ADHD. And so we know that a child who has one or both parents who have had that diagnosis is made, they're far more likely to have the diagnosis themselves. So genetics, of course, a huge role, but environment as well too. So we think about even in utero development. So there are some studies that suggest and really do support the idea that exposure to tobacco smoke in utero puts a fetus at risk for developing ADHD later on. There's also some concerns, of course, with alcohol exposure in utero. And then there's some exposures and things that people have often wondered if those are contributing factors. But I think it's important to talk a little bit about why there should be some hesitancy there. So a lot of talk about, does red dye, excess sugar, food preservatives, additives, those kinds of things. And so the research on that is when we study large groups of folks, what we see is that it's not supportive of the idea that exposure to red dye or excess sugar puts a child at risk. What I will say, though, is every child's different. And so some parents will notice that, hey, I notice when my child has more sugar, this is his or her behavior. But in general, when we study large groups, we do not see that there's a causal relationship there. Other things that we consider are things like prematurity has been tied to an increased risk, as well as low birth weight. So even if born on time, but a low birth weight could put a child at risk.
Good to know. And when we think about environments, the environment that a child lives in may not cause ADHD, but certainly could potentially make it express itself a little bit more. Would you agree with that, depending on the classroom or the family?
Sure. So I think certainly in households or in classrooms that have less structure to them, you're far more likely to see those symptoms emerge. And you might not see symptoms emerge in a child until much later if they are in a very structured environment. So that's sometimes how it gets kind of, if you will, missed in the early years because the environment has just helped support the child so much.
Yeah. So what is it that causes an attention deficit hyperactivity disorder from a cellular level? What's happening?
So great question. And I think one that we have a lot of theories about. Of course, we can't point to one single factor. But what we've done is in imaging, we've noticed differences in terms of size and development of certain parts of the brain, particularly that prefrontal cortex, where a lot of our executive functions are housed. We also see this on functional imaging. And so when we watch the parts of the brain work, we notice that in the prefrontal cortex in particular doesn't work as well in a child who has ADHD as compared to a child that doesn't. And then we know a little bit about kind of our catecholamines, and we kind of know about this backwards, right? So the medications we use to treat ADHD increase certain catecholamines, so norepinephrine and dopamine. And so the hypothesis is that, well, there must be a problem with either metabolism of those, the brain isn't generating them enough or metabolizing them too quickly. And so we've kind of backed into that particular explanation.
Yeah. When we talk about the prefrontal cortex, is that something then that just matures a little bit later for those kids, or is that an issue like their whole life?
So that's a really great question. Something I emphasize a lot to parents is our brains, particularly in the prefrontal cortex, will develop into our 20s. So a child who has ADHD, who maybe is a little behind their same aged peers, is going to continue to have healthy brain development. And so the question is, of course, are they going to catch up? And that's difficult to answer. However, their brain will continue to develop as expected. And so we'll see that maturation over time.
Gotcha. Now, the signs and symptoms of ADHD are the primary ones are right there in the title. So we know that an attention problem can be there and hyperactivity can be there. What other signs and symptoms are associated with ADHD that we should really be on the lookout for?
So I think the other things to consider too is a child who is struggling in interactions with others, right? So a child who is having difficulty with friends. Maybe this is just because they're frequently interrupting their friends in conversation, and so their friends kind of shy away from them. Or the child who's very impulsive and is hitting friends. People typically don't want to be friends with another child who's hitting. So we look at that. We look at academic performance. As a child meeting their academic requirements? Are they moving up as they should be academically? And then how they're functioning at home. Again, how are they getting along with their family, with their siblings? Are they able to sit at the dinner table and enjoy a meal, or are they up and bouncing around and nobody's enjoying dinner?
Yeah. Abigail, you had mentioned that impulsivity is also an important part of this for a lot of kids. How does that end up showing up behavior-wise?
Yeah, so I think when we hear impulsivity, we do think about behavior directly. So I am frustrated and reach out and smack my brother or appear at school. But I also like to highlight with families, there's emotional impulsivity too that may not, manifest as aggression, but parents describe kids going from 0 to 100 with the flip of a switch. So I think that's an important thing to note, that we may not see the disruptive behavior in the aggressive or destructive sense, but we can see these big and very quick reactions.
Yeah. As we think about attention, that certainly could come across as, being able to focus in on a task for a very long time. But there are some other things that may be more subtle in terms of behavior. So just as an example, it may be a kid who's frequently daydreaming. They don't seem to listen, or they're forgetful. Right. Those are other common things that you could see with this, other than just not being able to focus on something.
Right. And you might observe those children to be disorganized. You look at their lockers, their book bags, their bedrooms, and it might look like kind of a state of chaos. Relatedly, losing things necessary for tasks and activities. Did I bring home my math book? Do I have my lunchbox, my water bottle, or my baseball bat? Parents and teachers can be giving lots of reminders for those things for children struggling with the inattention.
Yeah. And the hyperactivity part of it doesn't necessarily mean a kid is running around all the time. I mean, there are other ways that hyperactivity kind of come out, like fidgeting, for example, maybe not stopping talking, just
yes.
talk.
Yes.
So it's really their mouth that's running, not their legs. Mm-hmm. And, or they can, maybe interrupt or have trouble waiting for their turn, those kind of things.
Yeah, definitely. We hear parents telling us, they just cannot play quietly. I can be in the other room or in another space, and I hear not only kids playing, but my child stands out as being especially loud. So maybe they're not climbing all over the place or running laps around the house, but they're heard or seen in other ways.
Yeah. And then, Kristina, it would seem that there are other things than just ADHD that could potentially cause these behaviors. And we may observe children who are having difficulty in the classroom, that maybe have difficulty getting along with their siblings or with their friends. What other problems should we be thinking about rather than always just going straight to ADHD? I would suspect there's some other things that should be in our differential diagnosis.
Absolutely. And I think they fall across a variety of categories. So first we have just development in general. So things like intellectual disabilities, learning disorders, a child who's struggling to read because that part of the brain isn't functioning as it should be, may look very inattentive just because they're struggling to decode the words on the page. Children who have certain genetic syndromes, so things like Klinefelter syndrome or things like Fragile X, can look and may indeed have ADHD, but there's also something else going on there too. We think about other psychiatric conditions. Inattention is a symptom that is seen across a variety of our psychiatric disorders. Anxiety, for example, depression, post-traumatic stress disorder. That's a common one that we'll see and hear about. Children who are frequently thinking about past trauma, they're not paying attention in class. They're struggling to pick up material. But they on the outside look just to be inattentive until we figure out what they're thinking about during that time. We also think about other medical conditions. So lead poisoning, for example. So especially in a young child whose behavior is concerning for hyperactivity, impulsivity. Thyroid disorders, again, not common, but something to think about. And then we also think about other things like medications. So a child who maybe needs a lot of albuterol, for example, or who needs high-dose steroids for periods of time. They may look like they have ADHD when in reality it's something else.
Yeah. Vision and hearing, I would have issues with those that may cause a problem in the classroom. So we certainly want to make sure that they're seeing and hearing okay.
Absolutely.
And a lot of this symptoms that we think about with ADHD kind of overlap normal development in younger kids. And so are there situations where you see it could be a parenting skill problem rather than a kid problem? Because maybe the kid is really just being age appropriate, but the parent's not necessarily setting limits or disciplining in an appropriate or effective way. Do you see that quite a bit too?
Absolutely. Or expectations are exceeding what is appropriate for an age. So particularly perhaps a parent who has an older child, and here comes the second one, and they're expecting behavior like their older child when the little one just isn't there yet. Or we sometimes will see this in the classroom. A teacher who maybe has taught 5th and 6th grade is now coming back to work with 3rd grade and expecting behavior more like a 5th or 6th grader. And so looking at those expectations, structure, routines, consistencies are very important as well.
And then at the other end of the spectrum with the teenagers, substance abuse, we should think about that too, correct?
Absolutely. So a lot of times, depending on what substances are being used, will look very much like ADHD.
So then how do we diagnose ADHD? How do we separate it from all of those other possibilities? So
great question. So I think one of the most important things to know is this is based on a clinical interview. It is not necessary or required to undergo psychological or psychoeducational testing. Those can be components of an evaluation, but they are not necessary. So a good clinical interview that involves information from multiple sources. So if you have a child who can give you information, or a teenager, parents, daycare providers, teachers, if the child's participating in extracurricular activities, coaches, any activity the child's in, you really want to get a lot of different information, because in order to make the diagnosis, you need to have symptoms that are impairing in more than one setting. So like I share with families, if your child only looks to have ADHD in the classroom, but not at home, we're missing something, or vice versa as well. And so really the more information you have, the better. And then you're looking for those symptoms. The other thing you're looking for is the history, right? So is it possible that all of a sudden here comes a 12-year-old who's never had any concerns for ADHD, and now all of a sudden could that child have ADHD? It's possible, but typically when we look backwards, we're going to find some evidence. It may be subtle, particularly if the child is above average academically or intellectually, but we should see signs. And so taking a good history, really finding out what those early childhood years were like, what teacher feedback was being given at that time, can really help us tell, is this what we've got going on, or is there something else?
Yeah. When I was training Connor forms, I remember those. I think they're Vanderbilt forms too. Are those still in use today?
Absolutely. So we love the Vanderbilts. They're free, which is a great thing, and can be given readily to teachers. We have them for parents. And so we can have them initially for diagnosis, but also for follow-up, which makes them great to use, very quick and easy to fill out. So we do like to get those whenever possible. Connor's still exists. And so some folks are using those too.
Yeah. And do they have the long form and a short form? Is that still... I'm pulling back now because I do emergency medicine and I don't diagnose or follow a lot of kids with ADHD these days. But there was a time that I did. And I remember the long ones were particularly helpful when you were making the diagnosis, and then the shorter ones kind of helped you guide, management if you needed to change medicine or change doses. That's still where we are.
Yes.
Great. So then, Abigail, once we have determined that a child has ADHD, what are some treatment strategies for managing the condition?
Right. So as Dr. Jiner has already mentioned, medication is often a component of treatment of ADHD. I think the estimates are about 2/3 of kids with ADHD are treated with medication. And in many cases, medication only, but that's not the only option. There are many behavioral strategies that also have a lot of science behind them that can be really simple but really effective. So in thinking about something to use in school, like a daily behavior report card, getting really consistent and routine feedback, as well as daily communication with parents about how a child is progressing towards their goals. So we like to think about that as an option for our school-age kiddos. Somewhat relatedly, for children who do have a diagnosis, many children would then be eligible for an IEP under the category of other health impaired or OHI. And so while we're not devising those plans, As psychologists, we're often working with families to make them aware of these resources and supports that their child may benefit from at school.
Yeah. And these are just going to be accommodations in the classroom that hopefully will help a child be able to pay attention longer.
That's right. So it could be an accommodation, maybe their desk is closer to where the teacher's teaching, or maybe they have an extra set of books if they're especially forgetful. So it could be things like that, but it may also be they really struggle in this large group setting. So we're going to do some pull-out instruction for reading to support learning in that area. So it can be a little bit more specific and intensive as needed.
Yeah. What about behavioral therapy for older kids in terms of like CBT, cognitive behavioral therapy? Is there any role for that in ADHD, or is that more anxiety, depression kind of?
No, I certainly think CBT has its place. Probably heavier emphasis on the behavioral strategies. Parent management training is another option for kids, throughout their schooling, and thinking about strategies parents can use to support behavior at home, as well as organization with schoolwork and accountability and promoting independence, because we don't want kids in high school having to be hounded. But if we can teach them skills and strategies to stay on top of their schoolwork and not need as much support from parents, that's really the goal.
Yeah, absolutely. And then, Dr. Jiner, let's talk about the classes of ADHD medication. And our primary audience today are pediatric providers. So I'm sure this is what they're really waiting for to hear about, especially given that so many kids with ADHD are treated with medication. Traditionally, we think of the stimulant kind of medication like the Ritalins and the Adderalls and such. To kind of walk us through the different classes of ADHD medications and how each of those work.
Sure. So I think about them kind of as two big broad categories. So one with the stimulants, as you mentioned, and within the stimulant category, we have kind of two different categories as well. So one, you have your amphetamines. So thinking about medications along the lines of Adderall, Vyvanse, for example. And then you also have your methylphenidates, which are more of your Ritalin-based products. Both of these sets of stimulants work similarly in that they increase norepinephrine and dopamine, particularly in that prefrontal cortex as we were talking about earlier. They go about it in slightly different ways. Amphetamines have kind of two routes in which they do it. Methylphenidates have one. But in general, the goal is to increase those two catecholamines. On the other side are our non-stimulants. And again, we can kind of divide them into two broad categories. One, we have the alpha adrenergic agonists. So these are medications like your clonidine, longer acting, known as Capve, your guanfacine, or the longer acting Intuniv. And these medications really, again, working in the prefrontal cortex, really increasing the norepinephrine there. And then the one little last category I would include in the non-stimulants are our selective norepinephrine reuptake inhibitors. This is kind of a unique class of medicine. They actually were designed to be antidepressants, but found not to be great antidepressants, but had some benefit with ADHD. And so again, they work by inhibiting the reuptake of norepinephrine. And so there's two now on the market. There's atomoxetine, known as Strattera, and then the newest one, Viloxine, known by their trade name as Quellbri, and that's more recent. I like to always point out, what's special about Quellbri is it can be opened and sprinkled. So that's what makes it a little unique as compared to atomoxetine, which needs to be swallowed whole. So again, everybody kind of working together. The data really supports stimulants as first-line treatment. So they have some of the best records in terms of all of medicines that we use in terms of their efficacy, their safety data. And the non-stimulants are used in cases where we can't use a stimulant, which are relatively rare, or in cases where a stimulant's not sufficient or a child just doesn't tolerate it, which happens from time to time.
Yeah. And all of these medications throughout with the pandemic, has there been any issue with the supply chain? I know in my world, antibiotics, suddenly we're having some issues with those being in stock. Is that also true with these stimulant medicines?
Yes. So Adderall XR, one of the amphetamines, as well as the short-acting Adderall, has recently suffered a supply chain shortage. And so currently that's something many providers are facing, families are facing, trying to find these medications. The reason behind this is a little unclear, but they're suspecting well into 2023 potentially. And much like I could imagine with the antibiotic shortage, it is causing some challenges for our families and causing at times the need to switch medication.
Yeah. Now, when you're starting medication, it can be difficult to know where to start. And I know from my experience from way back when, it would seem that too low of a dose could be problematic, but also too high of a dose could be problematic. And trying to find that sweet spot could be challenging and sometimes frustrating for parents. And almost, they feel like, oh, maybe the doctor didn't know what they were doing because it wasn't enough or it was too much. But it really, how each kid metabolizes the drug too. You could have two kids who weigh the same and they have very different doses. So speak a little bit to how you arrive at the perfect dose.
Yeah. So a little bit, it's a challenge, right? So a couple of things that I think about is one is, where do you start, right? So I always start with the stimulant unless for certain reasons I cannot. And then I always start with the lowest dose that we have. So let's say we're talking about with the methylphenidate. So typically 10 milligrams is where we're going to start. And the beauty of the stimulants is that you can increase the dose very quickly. Different from other medications, antidepressants, things like that. So after about 5 days, it's time to go ahead and go up on the dose. And so we tell parents what we're watching for, right? So 1, we're watching to see improvement of symptoms. 2, we're watching to see how long the medication lasts. And we have a rough idea of how long it should last. So if we're not hitting that mark, it's time to increase it again. We have rough estimates based on weight, based on some of the studies and trials that have been done. And so we have kind of a rough idea where we're going to end up. But I always encourage pushing the dose. As I always tell parents, worst case scenario, you have one really horribly bad day and then you pull back. But we do know that if you get the dose too low, then you're going to have some really bad days. So I tend to favor pushing a little faster, every 5 days or so, until we kind of hit that sweet spot. And again, as you mentioned, every child's different. Younger children, typically you're going to require a little bit more than a child who is older, but of about the same weight. And that just has to do with metabolism. The little ones, their metabolisms are just high and they're burning through medication, whereas our older ones have settled down in their metabolisms. And oftentimes we don't need to increase the dose as they grow.
Yeah. Parents often will be concerned that these are controlled substances, that they can't have unlimited refills, and that may make it seem like these are more dangerous for kids. So how do you counsel families on the safety and what are the real risks and possible complications of these medications?
Sure. So I think, safety being first and foremost. So why are these medications controlled? I explained a little to families that unfortunately medications can be used as they're prescribed and they can also be used not as prescribed. And so for individuals who are using them in an unprescribed way, they can cause a person to feel high or euphoric. And that, as you could imagine, could cause a problem. When they're used as they're prescribed under the safe management of a healthcare provider, they're very, very safe. They're not going to cause euphoria. They're not going to cause a person to become high or addicted, if you will. And so that's important to know about, and that's why they're so highly regulated. But again, very safe under the watchful guidance of a healthcare provider. Main side effects, particularly with our stimulants, is a decrease in appetite. So we do watch for growth. We want to make sure kids are growing and gaining weight like they should be. I always tell parents, middle of the day is going to be the meal that gets hit the hardest. So you've got some kiddos who do great at breakfast. They eat a ton at dinner and a great bedtime snack. If they're growing well, it's okay that lunch didn't go so well. Headaches and abdominal pain are the next most common ones. Headaches, if you skip lunch, like any of us who might skip lunch, end up with a headache, so can kids. Belly aches typically occur if you take it on an empty stomach. Some stomachs just don't like medicine without food. Other side effects parents really are concerned about, appropriately so, is my child going to be irritable, cranky, or grumpy on the medicine? And so what we always talk about is if you see an irritable child on a stimulant, what time of day did it occur? When that medicine starts to wear off, here come their symptoms again. And that can present as irritable as well too, versus a child who took the medicine and an hour later became irritable. That's different. That child's not responding well to the medication. And then probably the last concern that we have and parents often bring up to us, not a common thing we see, but something I always like to address is my child going to be a zombie? Is my child going to lose their personality? And the answer is, can it happen? Yes. However, again, like we talked about, stimulants, you know right away. So if it happens, you stop the medication or pull back the dose. Typically, one of two things has happened if you end up with that. You've got too high of a dose or you've got the wrong stimulant for a child. Usually, if you're trying to use a very long-acting stimulant, let's say Adderall XR, Vyvanse in a young child, 6 or 7 years old. So those are the main side effects that we counsel about, that we talk about. I really emphasize and encourage healthcare providers to have this conversation up front. This anticipatory guidance is what helps families feel confident in maintaining the medication. Otherwise, you see a lot of families back who've stopped it, so that they know what to look for.
Yeah.
They can call you if they need it.
Yeah. It's unfortunate because a lot of kids, the very behaviors that get in the way of school and working and maybe getting along with siblings and such, can also be somewhat endearing. And so when their personality does change, that can be problematic for parents. However, it's not a permanent change, even if they do have that, right? You stop the medicine, they're still themselves. It doesn't change their personality.
Yes. And so what I tell parents is what we're looking for, your child the best. So we want your child who's able to be in control and controlling themselves rather than the symptoms kind of controlling their life for them. They're in control and they're making decisions. And is that child going to look different? Yes. But at the end of the day, you should still recognize your child. And if you don't, then we've got a problem.
Yep. Abigail, we've talked about monitoring treatment with medication and titrating the doses up and down and trying to find that sweet spot. From a behavioral standpoint, how do we monitor ADHD treatment, and when do new strategies need to be implemented?
So I think for the children who are being medicated and receiving behavioral treatments, we can still use some of the Vanderbilt data to kind of guide decision making with whether behavior plans need to be tailored or modified at home or school. But I do like to think about the more data we can be collecting and reviewing on a routine basis, the better. What we don't like to see happen is for us to be relying solely on grades, and we're only going to get those 4 times a year. So, or when parent-teacher conferences roll around and a parent all of a sudden finds out they're failing across the board. So that's not the type of data we like to use. I think certainly we'd hope to see improvement in those areas. But again, something like a daily behavior report card that can foster that daily communication and give not only the child, but the parent that frequent feedback. I would say that's really the direction we want to be going.
Yeah. What exactly is the parent's role in helping these kids?
So I do want to highlight, and I think it's worth mentioning that because this is highly heritable, we want to consider what we are asking of parents in terms of intervention implementation, and making sure that if parents need reminder calls or written recommendations or opportunities to kind of teach back the interventions that we're suggesting, that can be really valuable. But I think a parent's role can be that advocate. And so communicating regularly with the teacher. If a school has been maybe dragging their feet a little bit on providing extra supports, well, now we have this diagnosis and we have all of this extra data to say, look, we're really struggling in these specific areas. What more can be done to support my child's learning and behavior in the classroom?
Yeah. Speaking of schools, and schools each district's going to really vary in terms of the expertise that they may have, availability of school nurses. Some schools have pediatric clinics right in their school. Others do not. What's the ideal situation of a school supporting these kids and families?
So I like for us to individualize a behavior plan to the extent possible, but many of our classrooms will have kind of class-wide behavior plans built in. I think that can work for the majority, but when possible, if we need to tailor that to an individual's needs to promote progress towards goals, whether it's completing work or not only completing the work, but remembering to turn it in, or keeping your hands and feet to yourself. Sometimes we need, at least initially, to tailor things a little bit more specific to at the individual level.
Yeah. It's really the parents, the school, and the medical home, and the psychiatrist, and the psychologist. I mean, really, it's a team effort.
Definitely
that
is.
everybody has to have their, their point of view and their lens
Right.
to improve the lives for these kids.
And one other thing I'll say is that when we're working with teachers and parents, these kids get a lot of feedback throughout the day, and it's often negative. So quit tapping your pencil, quit touching your sister. And so if we can catch them in those moments where I really like that you sat down and got to work straight away, or you're doing a really nice job sitting so patiently, and kind of reframe the attention and energy that we're spending, I think that can go a really long way for these kids as well.
Yeah, absolutely. Kristina, what complications or risks are associated with poorly treated ADHD? So, I'm certain that this is still an issue today, as it was back, when I was in private practice, that there were some parents that just like, I don't want my kid on any medicine. And so if they, obviously there are a number of kids that can be controlled in their environment, manipulated in such a way that they are able to be successful despite the ADHD. But let's say for those kids who aren't on an optimal dose, and this is ongoing, or maybe it just doesn't come to anyone's attention, what kind of problems can arise from poorly treated ADHD?
So I think that's a great question. And, I often hear from parents, well, I'm going to, I don't want to give medicine on the weekend or in the summertime and things like that. And so I think the biggest things we talk about is safety. So, you have a child and they're out riding their bike on a beautiful day and they're not paying attention to their surroundings, and they come to a crosswalk, and instead of looking both ways, they just ride their bike out into the street. That puts them at risk of being hit. Or you have a child who is with a parent in a busy parking lot. They're excited to go into the store. Again, kind of bouncing around, hopping, jumping, not really paying attention to the cars coming and going, and they're at risk. And so we do see a lot of accidents that, of course, we know can put people at serious harm. We also see other things, though. So educationally, a child who is struggling may not advance in the way that they should. They may not receive the education that they should, which has long-term impact on employment. We also see a lot of more depression. These children, as they get older, begin to realize that something's going on. I'm struggling and I'm working so hard and I'm not progressing like my friends. And they can internalize that. And so we start to see higher levels of depression. Of course, things such as suicide. We also see things like just poor decision making. So, again, a little impulse control. If it's not there and a friend offers you, some alcohol, some tobacco, you might say yes, just not thinking first. Or you get behind the wheel of a car and are driving too fast, or have had something to drink and driving. And so there's a lot of things both in the short term, but in the long term that we really worry about for poorly controlled or just untreated ADHD.
Yeah. Even when ADHD is treated optimally, often there are other what we call comorbidities, especially with mental health issues. What are some of the more common things that can go along with ADHD, even when it's well controlled?
Absolutely. So we always talk about that this is the rule and not the exception. So if you see ADHD, you've probably got some other things there. So very commonly, things like oppositional defiant disorder or conduct disorder, things such as tics are often comorbid with ADHD. We think about anxiety or depression. We think about specific learning disorders, and that can be a little challenging at times to tease out, but you can certainly see both of those together. We often see in autism spectrum disorder, ADHD is the most common psychiatric diagnosis. So we always want to think about, do we have those two together? So again, always being on the lookout for what else is there, because more than likely there's something.
Yeah. You mentioned tics, and sometimes when you start the medicine, if I recall, you can see increase in tic movement. So if a kid had them, and then the medicine kind of seems to make them come out a little bit more. Is that your experience too?
So there's been a lot of data and research to look at that question, because a lot of folks notice that they feel like, gosh, I started the medicine, here come the tics. And what really our data has shown us is that they're probably true and unrelated. And so the teaching used to be, you don't use a stimulant in a child who has tics, but now we know we don't need to worry so much about that. Oftentimes, the time at which we're treating ADHD and the lifespan of a child is also the time tics are most commonly seen. And so they just happen to come together. There's been some data to suggest that treating ADHD well can actually lessen tics. Certainly from time to time, you will run across a child whose tics seem to worsen. And there are medication adjustments and things that can be made. But typically, I always encourage still starting with the stimulant medications. And then we can always adjust if needed.
And in my experience, the less attention you pay to tics, the faster they are just to go away on their own. Absolutely. And if you point them out, then they, they stay and don't go away necessarily.
Absolutely.
What about the long-term outlook for kids with ADHD? So we talked a little bit about the brain maturing into the 20s, but there are a lot of adults with ADHD too, correct? What are the chances in an individual kid that this is going to be a lifelong thing versus just temporary?
Sure. So the data seems to suggest that about 2/3 of children who've been diagnosed with having ADHD will have some level of impairing symptoms as an adult. Now, that doesn't mean necessarily that a child will still meet full criteria as an adult for the diagnosis. They may just have some impairing symptoms. Typically, we see the hyperactivity and impulsivity kind of fade into the background. The inattention tends to be more of a concern. And we see that, of course, play out in many different ways as adults. So it is something we still do see into adulthood. And unfortunately, at this time, we don't have a way of predicting which child or teenager will go on to continue with these symptoms.
Yeah. Abigail, adults with ADHD, is the management similar to in kids? Is there some different things that happen with adults?
I would say it's largely similar. I mean, we want it to be developmentally appropriate. I don't think an employer is going to support, a daily behavior plan. However, some of those strategies that structure the routines, I think if learned early enough, can be carried into the workplace or even into, relationships, because that could be a source of conflict and concern, not only with peers when you're school age, but also as you move toward, romantic relationships as well.
Yeah. I would imagine that the careers that people choose, hopefully, are somewhat dependent on whether they have ADHD or not. So if I have ADHD, maybe being an accountant and sitting and looking at numbers all day is not necessarily going to be the most rewarding career.
Yeah.
As opposed to, something where things are changing, I'm on my feet. Oh, emergency medicine, for example. It would be easier for someone who does have ADHD kind of at their baseline.
Yeah.
Whereas school, it's the same across the board, unless we're modifying it for kids.
Definitely. I think there are those settings where someone with ADHD can certainly thrive. It's not to say someone with ADHD can't be an accountant, but they may rely on certain strategies to really make sure the attention to detail is there and that they're able to persist in those tasks that require sustained mental effort and things like that.
What are some of the hot topics in ADHD research? Where are we learning more, and what does the future look like for kids who have this disorder?
So I think one of probably the most exciting things that's come up and we're hearing more about is this video game that can treat ADHD. So right at the height of the pandemic, back in 2020, the FDA approved a video game device that goes by the trade name EndeavorRx, and as a treatment or part of a treatment plan for ADHD. And so it just like to share with folks what we know. So it was designed to help children ages 8 to 12 kind of improve intentional control. And so it's, as I understand it, kind of a space-like theme in which children are moving about and doing tasks that require attention shifting too. And so helping them develop those tasks. And there was data sufficient to have the FDA come out and say, you know what, I think we can approve this for use as part of a plan. So by no means is it considered to be the only mode of treatment, but it could be part of the plan, relatively well tolerated. And so that is kind of the newest thing that we're looking at. The data, I would say, is still young, right? And so we're not, we can't definitively say that, yes, every child should, between the ages of 8 and 12, should be playing this game, but something to kind of keep back burner. Other things that I think are coming up is how do we treat ADHD in certain populations? For example, those with autism spectrum disorder. We know that they respond a little differently to medications. And actually the data is lacking in helping us understand that. Or how do we treat ADHD symptoms in those with substance use? We know that's a comorbid condition, and there's been a lot of controversy about is it appropriate to use stimulant medicines. And then I think the other thing too is identifying ADHD, right? So ADHD has been described as both overdiagnosed and underdiagnosed. And so how do we better understand it as a condition? How do we better identify it in all populations? How do we better identify it in adults, for example? We have many adults who actually don't come to medical attention until their children are diagnosed. So I think learning more about how we do a better job at catching the diagnosis earlier so that we can start treatment and whether it be behaviorally and or with medication and help people be more successful.
Yeah, absolutely. Is there any move toward looking at genomics as a way to figure out which medication might be better for a particular child? And we've had some episodes of PediaCast on this in the past, and there's a lot of work in genomics that's happening here at Nationwide Children's Hospital. And I just wondered if that conversation has started in your world.
It has. And so what I tell folks about is, wouldn't it be great, right? Wouldn't it be great if we had this little cheek swab we could do and out pops a report and says that, this is the medication to start with. And wow, that would be fantastic, right? Save so much time for many families. The challenge is that the data just doesn't support it right now. We wish it did. It'd be great. But what we found is when we look at the reports and it's been tried, it just hasn't been terribly effective in helping us choose a medication. There's one exception to this probably. In certain populations, the use of atomoxetine, which is a non-stimulant treatment for ADHD, there's some utility for that type of testing. However, typically it only helps us adjust the dose. So it's not going to tell us that, yes, you should use this, more about like what dose do you need to use. So I tell families are often asking, gosh, I wish this data were there and the science were there yet, but we're not quite there yet. And so sometimes it does seem a little like we're, kind of picking one medicine after the other, which can be incredibly frustrating. Yeah. But I think, again, working together with your healthcare team and taking it trial by trial, I think can be very rewarding. And maybe in the near future, we'll have better instruments to help us.
Yeah, more to come.
Absolutely.
All right. Well, really appreciate both of you stopping by today. Before we go, Abigail, remind us about all the behavioral health services here at Nationwide Children's Hospital and our On Our Sleeves campaign.
Yeah. So as you well know, the behavioral health system here at NCH is vast, which is great. We have expert teams here downtown and throughout the city, serving children of all ages with a number of different presenting concerns. I think when it comes to ADHD in behavioral health, we're most often working with outpatient psychology, primary care colleagues doing that assessment, diagnosis, and treatment. But we also are fortunate enough to have therapists and counselors embedded in a lot of our schools. I know we have the ADHD Academy as well that offers support to parents of children who have been diagnosed and are looking for some foundational skills and additional information about the diagnosis and treatment options. In terms of On Our Sleeves, the mission is to give free, evidence-informed mental health resources to every community in the U.S., which is huge. So the content is really helping to break stigmas and increase that mental health literacy. The resources are created by experts here at NCH, and all of that info is available at onoursleeves.org, as well as on social media.
And we'll put a link to On Our Sleeves in the show notes for this episode 82 over at PediaCastCME.org. And we'll also have links to the Big Lots Behavioral Health Services at Nationwide Children's and the Psychiatric Crisis Department at Nationwide Children's Hospital. We'll have links to all of those things. I also want to point out that on our podcast for parents, so plain PediaCast without the CME, we have covered lots of behavioral health topics. And we have a playlist of all of those episodes packaged together over on SoundCloud. And just, for example, some previous topics have been toddler behavior, depression and anxiety in kids and teens, preventing teenage suicide, managing holiday stress, helping kids and teens through the school year, tackling boredom, bullying, self-care and wellness for moms, and much more. We really have just a ton of behavioral health episodes. And so I think that'd be a great resource for your patients and families out there, just to let them know that we have this resources available. And again, we'll put a link in the show notes to that playlist over on SoundCloud so you and your patients can find it easily. We're also going to have some links to up-to-date articles related to ADHD, lots more detail in terms of epidemiology and the pathogenesis, clinical features and diagnosis, treatment and prognosis, treatment with medications, pharmacology of the drugs used to treat ADHD, and also an article I found pretty interesting on sleep in children and adults with ADHD. Sleep is important for all of us, and most of us don't get enough of it, and so that can be helpful for these kids. And this article spells out exactly how and why pretty nicely. So we'll put links to all of those things in the show notes as well. So lots more if you want to dig a little bit deeper. In the meantime, once again, I want to thank Dr. Abigail Caserta and Dr. Kristina Jiner. Thanks so much for stopping by today.
Thank you, Dr. Mike.
It's been a pleasure. Thank you.
We are back with just enough time to say thanks once again to all of you for taking time out of your day and making PediaCast CME a part of it. Really do appreciate that. Also, thanks to our guests this week, Dr. Abigail Caserta, Pediatric Psychologist, and Dr. Kristina Jiner, Pediatric Psychiatrist, both with Nationwide Children's Hospital. Don't forget, you can find PediaCast CME wherever podcasts are found. We're in the Apple and Google podcast apps, iHeartRadio, Spotify, SoundCloud, Amazon Music, and most other podcast apps for iOS and Android. Our landing site is PediaCastCME.org. You'll find our entire archive of past programs there. Show notes for each episode, the CME information, our terms of use agreement, and that handy contact page if you would like to suggest a future topic for the program. Reviews are helpful wherever you get your podcasts. We always appreciate when you share your thoughts about the show. And we love connecting with you on social media. You'll find us on Facebook, Twitter, LinkedIn, and Instagram. Simply search for PediaCast. You've listened to the podcast. Now be sure to claim your free Category 1 continuing medical education credit. It's an easy thing to do. Simply head over to the show notes for this episode at PediaCastCME.org. You'll find a link to the post-test in the show notes, again, episode 82. Follow that link to Cloud CME, take and pass the post-test, and the Category 1 credit is yours. Super easy, right? And again, we do offer credit to not only doctors, but also nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and dentists. You just want to be sure that the content of this episode matches your scope of practice. Complete details are available at PediaCastCME.org. Also, don't forget about our evidence-based podcast for moms and dads. That's plain PediaCast without the CME. Lots of pediatricians and other providers also tune in as we cover pediatric news, answer listener questions, and interview pediatric and parenting experts. Shows are available at the landing site for that program, PediaCast.org. Also available wherever podcasts are found. Simply search for PediaCast. Thanks again for stopping by. Have a really terrific holiday season with your friends and family, and then come on back here in 2023 for more evidence-based content aimed at keeping kids safe and well. Until then, this is Dr. Mike saying stay informed, keep it evidence-based, and take care of those kids. So long, everybody.
This program is a production of Nationwide Children's. Thanks for listening. We'll see you next time on PediaCast CME.